Welcome to this narrated presentation summarizing the highlights from Chapter 5 in the Evans and Sullivan book on dual diagnosis. And in particular, as you view this presentation, recognize, so this is a baseline as we begin to look at the process of assessing psychiatric disorders and also introducing or really reintroducing the idea that interventions need to be planned for the appropriate level of care. Please recognize that this presentation highlights some of the main points that were made in the chapter. It is not intended to be a substitution for reading the chapter, so please make sure that you read the chapter, not just view the highlights on this presentation. The first item that the authors address is what I call the distinction between a functional versus a differential diagnosis. And it's a little bit of a abstract concept, but the short story is that when we're assessing clients for psychiatric disorders in particular, in addition to looking for what I call the more formal, or what they call the differential diagnosis, i.e. the DSM-5 diagnosis, we're also looking, though, for what is it that's happening functionally, how are they being impacted by this illness. And so the example that they use in the book is that if you have a client who is actively suicidal, then functionally your concern is that he or she is suicidal. From a diagnostic perspective, you may then have identified that he or she meets the criteria for major depressive disorder. So recognize that diagnosing includes both a look at how the illness, the formal diagnosis, is impacting the person, and the focus is oftentimes really on how does treatment need to address the problems or the needs, the challenges that the person is experiencing as a result of their condition. The authors then quickly move into an overview of the psychiatric assessment process. And as you look at the sort of some of the key elements that are listed here, my hope is that they feel very, very familiar to you, because when we talk about assessment, whether we're talking about assessing for substance use disorders or mental illness / psychiatric disorders, a couple things stand out. One is that in order to thoroughly assess a client, it's really, really important that we do a very thorough, very comprehensive assessment. They use the term biopsychosocial assessment. You've also heard the term biopsychosocial spiritual in the context of assessing for substance use disorders. But regardless, if we're going to truly understand the client and then ultimately determine how to proceed with the treatment process for him or her, it really is important that we do a very, very detailed job at understanding who they are. In the book, on pages 68 through 70, the authors have included their reference to what they call their, quote, cheat sheet, i.e. how assessments are organized in the treatment settings that they were working on. So please take a look at that. It also is really an outline for how people would do what I call a case presentation, a case study, things like that. You want to be familiar with all these concepts that are contained on those 3 pages, because they're really all essential elements of a diagnosis. A couple things, though, as you both read the book and look at this chapter. In the book, they make reference on a regular basis to the DSM-4 criteria. Recognize that we're now using the DSM-5 criteria, and so while the concept that they talk about apply, the criteria, when they make reference to criteria, are no longer accurate. You really need to begin to work out of the DSM-5 criteria, which is part of why you now have the DSM-5 book. Also, when you look at the cheat sheet for their client intake, and they talk in particular about what's called the diagnostic impression, in that discussion, they make reference to what's called a 5-axis assessment. The multi-axial or 5-axis assessment was eliminated with the DSM-5. So you might want to know it from what I call a historical perspective, but we no longer use 5 axes as part of the diagnostic impression of the client. Similarly, you're going to see a reference in their discussion to what's called the Global Assessment of Functioning, or GAF scale, GAF ratings. Again, that was eliminated with the DSM-5 criteria. There are functioning criteria that can be used that have been developed by the World Health Organization, or WHO, WHO. So when you look at these things, just recognize that there's been changes in the DSM-5 criteria, elimination of the multi-axial assessment, and also an elimination of the GAF rating scale. Everything else in that cheat sheet is going to be, I think, accurate and really a good framework for how you would organize an assessment moving forward. The other things that I'll highlight are pointed out on here is that the more information, the better. If a client comes in for an assessment and he or she is impaired, psychotic, etc., then we recognize that we really don't have the ability to do a thorough assessment. At that point, we're simply observing through symptoms and determining what needs to occur to stabilize the client. Similarly, and just like substance use disorders, sometimes we only have the client as our data source. Assessment is always much more accurate when we have more than one data source. So in addition to the client, we love family members, friends, relatives, if there's previous treatment records, if there's referral sources, if there's court systems. The more information we can obtain to conduct an assessment, the better. They state the obvious, and so I'll also state it here, recognize that in every situation, certainly for clients that we're looking at here, there's going to be more than one diagnosis. We're talking about dual diagnosis, people who have both a substance use disorder and a psychiatric illness. People may have more than one SUD. They may also have more than one psychiatric illness. So really, dual diagnosis, two diagnoses, isn't necessarily what you're going to be limited to. Clients will oftentimes present with multiple diagnoses, both multiple substance use disorders and potentially several psychiatric illnesses as well. Recognize that assessment is always tentative at the start, which means that we have impressions. We move forward based upon those. Over time, we get more and more information, and so the assessment process continues throughout the person's involvement with the treatment system. It's an ongoing and a continuous, really improvement process. The idea of a mental status exam, number one, is predictable and common when you're working in a mental health setting. It isn't necessarily as familiar to people who are working in a substance use disorder setting. If you're going to work with clients who have co-occurring disorders, it's an extremely important concept to be aware of. The reality is that these categories or these aspects of client assessment are really relevant to substance use disorder clients as well. And so there's a pretty detailed discussion of this that begins on page 71, continues over to page 72. So again, make sure that you're reading the book. But this is where, in addition to the collection of data, the interviewer is also looking for and assessing all of these items as a part of the overall assessment. How did the client appear? How did they behave during the interview? Was it, quote, normal? Was it unusual? Was there something odd or different about those aspects? Similarly, what was their attitude both during the interview and towards the interviewer? Was there suspicious? Was there cooperativeness? Was there guardedness? Those kinds of things, all of which influence the outcome of the assessment. We're looking for evidence, what they call psychomotor activity, kind of that restlessness, that kind of frequent motor activity, perhaps the moving of hands, tapping of feet, shuffling of feet, things like that. And looking for whether or not they appear to be, quote, normal, if it appears to be impaired, or it appears to be exaggerated. They appear to be sort of stimulated and things like that. You're familiar now with the concepts of assessing for person's affect and mood. We're also looking at speech and thought, and there's some reference in the book to are people speaking in what appears to be a normal manner, or is their speech pressured, is their speech rapid? Similarly, and in contrast, was their speech very, very slow? Is their thought generally appear to be coherent? Is it tangential? Do they go from one idea to another? And so we're looking to try to assess how, quote, normal or how different both speech and thought are. We look at are they reporting or do they appear to be experiencing either some disturbance perceptually or also responding to or reporting either auditory, verbal hallucinations, things that they are experiencing that aren't things that people around them are experiencing. Orientation is a fairly simple concept, but it's really basically we oftentimes, are we looking to see if the person understands the common things? Do they know what day of the week it is? Do they know what month it is? Do they know the date? Do they know the year? Do they know where they're at? Do they know who they are? Do they know why they're there? It's really orientation across multiple dimensions. Are they oriented accurately to person, place, time, space, etc.? Assessments of their attention, concentration, and memory. We're looking for cognitive impairments here. There's some pretty simple ways to test that. The book talks about things like serial sevens, counting backwards, those sorts of things. We're also doing not a detailed assessment of their intelligence, but really some simple ways to try to assess whether or not they appear to be of, quote, average or adequate or normal intelligence. And so they talk in the book again about a couple of different ways to assess that. Briefly, you're not going to have an IQ score. You're simply going to have a sense of the person's intelligence. And then lastly, the final factor that they talk about is, does the person appear to be cognitively, are they functioning pretty well intact? Do they appear to have good insight? Do they appear to have good judgment? We want to just see how those factors may be affected by the presence of a mental illness if there is such a condition. Certainly now, and as we talk about overall concepts of psychiatric assessment, clearly one of the things that we're taking a look at is assessing risk of harm either to self, i.e. suicidal intent, suicidal thinking, or potential risk of harm to other people, which might be intention to kill, i.e. homicidal ideation, or simply or not simply, but intention to hurt or to assault other people. And so we're assessing really and looking for the evidence as to whether or not either of these are present for the person. If there is, in fact, appear to be the presence of either of these, then at that point, we continue to assess further, looking specifically about, how long, how often, how frequently do they have these thoughts, how strong are they in their opinion, are they fleeting thoughts, do they experience them all the time, are they very intense, is it hard for them not to act upon those thoughts, are there any changes in how frequently they're occurring, and related to that, and then if they are talking about either of these, and not only are they thinking about it, do they know how they would do it? Do they have a specific plan to hurt themselves or to kill themselves or to hurt other people? And then if they have a plan, do they have access to the means? I.e., if they're talking about, for example, shooting someone, do they have a gun? Shooting themselves, do they have a gun? Overdosing, do they have a substance, access to substance? So we're looking for how, do they have such a plan? And if they have a plan, do they have access to the means that are part of that plan? And then I tend to be a behaviorist, and the authors, though, talk about this too, is that anytime a client comes in and has a history, a past history of either attempts to hurt themselves, attempts to commit suicide, or a history of hurting, harming, assaulting other people, anyone with a history of those kinds of behaviors is automatically at higher risk for engaging in those behaviors again. And they carry this out a little bit further on page 73 of the text. They talk a little bit about predictors of risk, and so you really want to take a look at the predictors of risk. They also talk about what we can do clinically to respond, i.e. the idea of what I call behavior contracts, or written contracts, written agreements, things like that. So take a look in the book at both what they call the predictors of risk as well as potential clinical responses if such intentions are identified. When the authors talk a little bit about some of the challenges, some of the things that complicate our attempts to accurately diagnose a client, they talk about the things that are noted here. One of them being that, in general, there's a fair agreement that people with co-occurring disorders, that it occurs on a very regular, it's a very common condition. The challenge is that, but even among various studies, there isn't universal agreement on how often it does occur. There's no universal agreement on incidence and prevalence of such disorders. And so you're going to see a link to a study that was done in 2014 in this module that talks about behavioral health across the United States. This looks at substance use disorders and co-occurring disorders. So there's general recognition that it occurs on a very regular basis, but there isn't always universal agreement on the exact extent of that occurrence. There's also acknowledgement that there is a high correlation between substance use disorders and other psychiatric conditions, such as major depressive episodes or depression, anxiety, attention deficit or attention deficit hyperactive disorder, many other personality disorders. And so we know that things that they tend to occur and can occur on a regular basis in combination with other disorders. If there is such a relationship, if a person has both a substance use disorder and a major depressive episode, then part of the challenge is to determine, are they what is referred to here, are they two independent conditions, i.e. does the person have literally a separate substance use disorder and complicated by the presence of a depressive disorder? Is there in fact some causal relationship? Is the person using substances because of their depression? Or on the kind of the flip side, are the psychiatric symptoms that we're concerned about potentially substance-induced? The example of that, for example, is that alcohol is a central nervous system depressant. So if somebody's using a central nervous system depressant on a regular basis and begins to report, experience, or you identify him or her as having symptoms of depression, is that depression an independent depressive disorder, or is the depression really an alcohol-induced depressive episode? And so it's complicated and it takes time, but we have to recognize that there are complications, which is part of why we tend to be cautious and we tend to look to get as much information in order to confirm potential diagnoses. So as a follow-up to those discussions or the acknowledgement of some of the factors that complicate the diagnostic process, they also then talk about what they call the diagnostic principles, and so quickly highlighting those here. They do talk about the importance of trying to do an accurate timeline to recognize what occurred first, i.e. were they experiencing depression prior to the use of substances. If that's the case, then evidence would suggest that they have a depressive disorder that is independent of their substance use disorder. And so we do have to try to have as accurate a history as possible. The other thing too, though, is that, and this really just occurs through exposure and experience, is that when you have an individual who is experiencing symptoms, but the symptoms are a part of their substance use history, then if they tend to have a less intense experience, they're different. There's a different quality to individual who's experiencing a substance use disorder only in comparison with an individual who has both a substance use disorder and an independent mental illness. And they talk about this a little bit in the last couple of pages of the chapter. For individuals who have what I call multiple complications, co-occurring disorders, then they tend to have more intense, more problematic, more sort of holistic patterns or problems or symptoms, and in contrast with someone who does not have a co-occurring disorder, they tend to have less impairment in general. So take a look at that discussion. The other thing, diagnostic, that is important to rule out actually substance-induced disorders is if the person has symptoms and the symptoms are resolved after a period of abstinence, then we tend to think that the symptoms were substance-induced, and so therefore the focus continues to be on the use of substances and not on separately treating an independent mental illness. They talk about they try to wait 4 weeks. Not everybody will wait 4 weeks, so recognize that that's a little bit of an arbitrary sort of discussion on their part, but there is good practice to say if we think it's substance-induced, then when the person becomes clean or abstinent, let's see what happens to their symptoms over time. And then lastly, they also talk about the fact that ultimately as professionals, what we need to do is just make sure that we not only understand the criteria for both substance use disorders and mental illness, but we also need to just adhere to the criteria. I may have a bias, I may be biased against, for example, independent psychiatric illnesses, but my bias doesn't mean I need to or I should ignore the criteria. Use the criteria, and that's part of what you're going to begin to be introduced to during this course. And as you practice moving forward, we try to remove our bias and simply say, does the person have these criteria? Yes, no. If they meet the criteria, the diagnosis is present. If the criteria aren't present, then they don't meet the criteria and they're not diagnosed. So take a look at that discussion as you close out the chapter as well. And finally, as we close the quick review of Chapter 5 here, they talk a little bit about the importance of after the assessment has been conducted, we then ultimately have a responsibility to make treatment decisions based upon the results of that assessment. Certainly a couple things that I would highlight is recognize that because assessment is an ongoing, continuous process, it's an iterative process. Information changes over time. Diagnostic impressions, diagnoses may change over time. So just recognize that the assessment itself and the findings from the assessment are fluid. They're subject to change as new information becomes available, as you see the client and how he or she responds to treatment. You may have symptoms that increase. You may have symptoms that go away completely. So we have to just acknowledge that it is a fluid, ongoing process that's subject to change. The other thing, too, that would drive decisions about treatment are that ultimately, whether we're talking about psychiatric conditions or substance use disorders, what we want to do is make recommendations that allow the person to get the treatment he or she needs in the least restrictive environment. We'll talk a little bit more about this when we meet face to face, but the least restrictive environment is no treatment, and if they need treatment, one step up would be an outpatient. A more restrictive environment would be intensive outpatient, partial hospital program, day programs. Step up from that would be residential or inpatient. Step up from that would be medically monitored, potentially a locked program. So we're going to talk about this concept, but recognize that people should be treated in the least restrictive environment, and they do a nice job of tying in a reference to using objective versus subjective criteria. We're going to talk more in this module about the patient placement criteria that were developed by the American Society of Addiction Medicine. So recognize that we'll explore this further, but these are some of the principles that would highlight the process and highlight the decisions that we come to. So again, this review is not a substitute for reading the chapter. I hope it's helpful, and I look forward to discussing it with you next time we meet. Thanks.